Hello everyone. Welcome to another Rafael Medina virtual subspecialty morning report. We're very excited to have another pulmonary and critical care subspecialty session. I know Deborah has an amazing case for us today, and we have a very special guest from the University of Michigan. And Maddie and Alex, do you want to introduce yourselves and tell the listeners why they should go into pulmonary and critical care?
Absolutely. Alex, you want to start?
Sure. My name's Alex Rabin. I'm a clinical associate professor of pulmonary critical care medicine here at the University of Michigan and the Ann Arbor VA, which is for those, actually, I didn't know where we were until about 3 years ago when I got here. We're in Southeast Michigan, so about an hour west of Detroit, if you know where that is. And it's great to be here. My focus is really clinical work, but I am really passionate about understanding environmental lung disease and how climate change and air pollution affects our lungs. And so that sort of morphed that into a little bit of a research career here too. And so love to be at this university and work with students and residents and wonderful fellows like Maddie, who I've seen all the way through and who's really she was really shining as a fellow, and is now we're very fortunate to have her join as faculty in our field. So Maddie, go ahead.
Thanks, Alex. What a wonderful introduction of me. I feel very lucky for that. Thanks for having me today. It's a joy to be here. This is one of the podcasts that I would listen to when I was in residency, so a really cool thing for me. Let's see. I just signed on, like Alex said, I just finished my pulmonary and critical care fellowship and the other kind of medical training in internal medicine at the University of Michigan. And I'm staying as a clinical assistant professor here at U of M and the Ann Arbor VA. And I think you asked why choose pulmonary and critical care. I could say a million great things about pulmonary and critical care. I could talk this whole session, but I will not. I'll say two things. The first is pulmonary and critical care is really special because you can do it all. You can be an outpatient doctor. You can be an inpatient doctor. You can be the primary doctor. You can be the intensivist. You can be the proceduralist, the consultant. You can do any of that, and you can do all of that. And so for indecisive people like myself, it was something that I really was drawn to, something important to me. And then the other thing that I'll say that is related to that is when I was a pre-medical student thinking about what it meant to be a doctor, the thing I was envisioning was someone who could help in all scenarios. And as I progressed through my medical training, I began to see that pulmonary and critical care could provide me the training to do that. And I really wanted to be hands-on at any moment in the patient's disease, whether that was in the clinic or in extremis in the hospital, or even at end of life. And so I think pulmonary and critical care kind of gives you a really nice opportunity to be involved in patient care at every point in the disease course.
Thank you both. That's fascinating the way you describe it. And a lot of the pulmonary critical care doctors I've met are able to handle any situation, whether outpatient, inpatient, or whatever it is. So it's always so fascinating. And Alex, we had a session on climate change and health a few weeks ago as well, like such a fascinating topic and its interaction with pollution and resistance and organisms and so on. It's really fascinating. Deborah, do you want to introduce yourself and tell people about your story a little bit?
Hi everyone, I'm a CPS team member for about, I think, 3 or 4 years, and I recently graduated in medicine, and I am super happy. I'm also a lawyer, but I pretend to just go in the medicine way, not law, and we'll be moving to the United States soon. So yeah, happy to be here.
We're happy to have you. Do you want to start with the first aliquot?
Yes. So it is a 83 years old woman with AML presenting with fatigue. She reported that she had been feeling fatigue for 6 weeks and weight loss. and she presented like a dry coffee in the same time, and deny any fever, chills, or night sweats. And I think I can stop here.
Before I throw the mic to you all, Maddie and Alex, I wanted to ask you, how do you approach like cough in general over 6 weeks, and how does the background of AML affect your thinking? I know we're gonna get more information shortly, but just in general, how do you think about it?
I'm happy to start, Maddie, if you like. Does that work? Okay. Yeah, so we could have a whole session about chronic cough, of course. And you know, that's probably if not the top complaint, one of the top two complaints that we see in the clinic, and also to a lesser extent probably in the hospital. And so when we see patients with a cough that's been going on for some period of time, we really, first thing we want to figure out, is it acute? Is it subacute? Is it chronic? So usually like a cough that's acute, you know, is going on for, Maddie's going to remember the exact definitions, about, I think, less than 4 weeks or so. Somewhere in between 4 and 8 weeks, 4 to 6 to 8 weeks, you know, it's somewhere subacute. And then of course, chronic cough is really a cough that's been going on for about 6 to 8 weeks or longer, a couple of months. And so, you know, the most common causes of cough, I'm sure you guys have all covered. They would be related to reflux, asthma, and postnasal drip, or some form of something tickling the throat that causes the cough. So those are the common things that we think about. But in this case, you know, immediately, you know, my index of concern or suspicion goes up in a patient who has apparently active treatment or has active disease with leukemia, because of course, with an immunocompromised patient of any kind, whether it's HIV or leukemia or hematologic malignancy especially, you know, the concern for infection is going to be, of course, quite elevated. So so those are kind of my first thoughts. Matt, you want to jump in with anything else?
The only thing I would add to that would be people with chronic disease often take medications, and I think a lot of times medications can have chronic cough as side effects. So I'll often think about immunocompromise and medications under the subheader of kind of exposures, like what are the things in the environment or the things that the patient is taking that could impact this particular symptom.
Wonderful. Thank you both. Back to you, Deborah.
Amazing. So going for the past medical history, the patient had AML that was diagnosed 30 months ago and evolved with polycythemia vera. She was on oral IDA2 inhibitor. Sorry, I don't know if I'll say right, but I'll put in the chat. Enacidenib for 24 months and then had a relapse of the disease. And currently is on FL3 inhibitor, gilteritinib, with excellent control of the disease. She also has like a psoriasis that was diagnosed like 2 months ago and started on cyclosporine. And originally was to receive like utekinumab, but had an indeterminate interferon gamma release assay. I'll add everything to the chat, sorry. And the patient was born in Germany, but has lived in the United States for the last 50 years and had no tobacco use and no allergies.
I just want to say I'm nodding my head a lot as you're saying all of these medications, but I don't know all of these medications, and I think that's okay as a subspecialist. we don't work in hematology oncology. There are lots of new drugs being produced all the time. And so when I see something like this, I'm going to Google, I'm going to Lexicomp to try to figure out what is the mechanism of action here. And I too cannot pronounce many of them. So you are not alone.
Yeah, and that's exactly what I do as well. And I wanted to ask you, how do you think about the interferon gamma release assay? In this case, it's like intermediate. Do you have any approach to it or how to think about it?
Sure. I can jump in. I mean, I think before we get to that, I just wanted to give a bigger overview here, which is that in general, like when we get these consults in the hospital quite frequently, and sometimes in the clinic as well, where basically you have a patient with cancer who presents with a new respiratory complaint, and oftentimes imaging, we'll get to the imaging, I'm sure, later, findings. And the question comes down to basically it's actually quite straightforward, which is in a way, which is it the cancer that's causing the symptoms, or is it the treatment of the cancer? So in this particular, and that's basically how I think about, that's how I usually approach these patients. And in the vast majority of situations, those are consideration. And when I say treatment of the cancer, I mean not just literally the drug, which causes a side effect, but also the immunosuppressive effect of the drug that then can result in opportunistic infections, like, for example, in this case, as we're talking about tuberculosis, something like that. So that's globally, I just wanted to mention that kind of approach to the case. To get to your question, Yusuf, so what does it mean that the patient had an indeterminate interferon gamma release assay? Certainly it's not reassuring. Gosh, and I wish Russell, our friend from Emory, were here to talk about the specifics of TB interpretation of IGRAs, or these quantiferons or T-spot tests. But in a patient who sounds like they're from Germany, so perhaps not from a high endemic area, who's lived in the United States, probably the risk is not particularly high, but it's not unusual to have an indeterminate IGRA where you're still left wondering, and so this is where, like, having preceding imaging or a sense of symptoms and things like that, and doing a clinical evaluation is really important to determine whether or not there's really sufficient concern for active TB. But the IGRA itself doesn't rule it out here, obviously.
I would say the other thing I would say is it's important to check your testing parameters and to make sure that when you're looking at the interferon gamma release assay, that you're looking at the mitogen reaction and making sure that you had an actual effect on the control test. And so many different institutions may be reporting this differently. So if we have questions about this, often I'll call the lab and say, hey, can you explain to me how your testing is laid out and where your variables are, just so I can make sure that this is actually a valid test and doesn't just need to be repeated. Sometimes if you can just repeat the test with another sample, you may be able to get more conclusive results. But usually I'll phone a friend because our lab technicians are really helpful and they can tell us how they run the tests and what things we should be questioning a little bit more in terms of validity.
Right. And yeah, and the way I always thought it was like to analyze the IGRA like an IgG. It's like if you're exposed, you might develop a response, but if it's negative, it doesn't necessarily tell us that it's not there. And if it's positive, it only tells me that the person is exposed, but doesn't tell me the status of the current status of disease. Is that how you think about it as well, and how you describe it to medical students?
Yeah, that's
Agreed.
exactly right. Yeah.
Wonderful. Thank you both. Back to you, Deborah.
Yeah, so going for the physical exam, the temperature was 99.7 Fahrenheit. Heart rate was 87. Blood pressure was 117 and 82. Respiratory rate was 15, and although O2 saturation was 96%. So the patient was in no acute distress. Cardiovascular was regular rate and rhythm, no murmurs, rubs, or gallops. On lung exam, had a layer of crackles in the right lower lung, just in the right lower lung. On abdomen was soft, non-tender, non-distended, no edema, and the patient neuro was okay. Oriented and time, place, no focal deficits.
And I think it's okay to get a little bit more information if you want, Deborah, before we
Okay, so
pause.
going for the labs, WBC was 5.2 with 82% neutrophils, 16% lymphocytes, and really rare some blasts. Hemoglobin was 11.7. Platelets was 258. And going for the chemistry, like they were basically normal, and the creatinine was 0.8. Bilirubin 0.6, and the rest it's non-relevant. And I think I can stop here.
Thank you so much. And I know we didn't get a lot of pertinent positives yet, but I was just wondering if you're at this point consulted for this patient who's just having intermittent cough, and what's your problem of like representation? How are you thinking about it, and what would you want next?
I think as both critical care doctors and pulmonary doctors, the first question I ask myself when I'm seeing someone, let's say even in the clinic, but certainly in the inpatient space, is this patient sick or not sick? And I think acutely, based on her vital signs, a couple of things stand out as reassuring to me. The first one is actually her respiratory rate. So whenever I think about people who are coming in with a respiratory complaint and a normal respiratory rate, I'm a little bit reassured right off the bat, right? And then I'll follow that up with looking at her oxygen saturations. Now I'm assuming that she's on room air with this oxygen saturation, which is also a little bit reassuring. In terms of other things that are a little bit abnormal in her exam, temperature, hard to say, maybe a little high, maybe hard to say, not officially a fever. And then these crackles in the right lower lung are pretty nonspecific. When I look at her labs, similar thing, her differential, a little bit neutrophilic predominant. Well, definitely neutrophilic predominant, and nothing else is jumping out. So at this point, you have a woman who's immunocompromised, who's had weight loss and indeterminate interferon gamma with no real high-risk profiles outside of the fact that she has ongoing malignancy, hematologic malignancy, and recent immunosuppression. So top of my differential right now would be an infectious cause, some sort of atypical infection that folks who are immunocompromised can be at risk for. But other things would be drug side effect, possible other environmental exposures. I would want imaging. We love pictures. I'd love to look at the lung parenchyma at this point. Alex, do you have other thoughts?
No, absolutely. I mean, I think at the very top of the list, of course, is infection. And to drill down a little bit more specifically, and I've seen some really good ideas in the chat here. You know, the types of quote unquote atypical infections, the types of things that present insidiously in a patient like this would be, as was mentioned, fungal infections, and specifically something like aspergillus, invasive aspergillosis. You know, patients can be really sick, but it really comes down, there's definitely a spectrum. And so that would be one of the top concerns. Certainly, pneumocystis pneumonia is another, PJP is another consideration. We shouldn't completely exclude the idea of typical infections and like pneumococcal disease or something like that. But of course, again, that would be a little bit unusual for it to fester for to go on for like 6 weeks at a time. So unless she has she could have multiple things going on at once. But I think she doesn't seem that acutely ill. So it's something probably a little bit more indolent. And then viral infections too shouldn't be forgotten. Of which there are many. So those would be at the top of my list. I think the other thing to add, Maddie, I think you did a great representation. Would be disease progression itself. And she's had fatigue and weight loss. Leukemia can infiltrate the lungs. So it's not completely excluded, and sounds like she's maybe doing okay, but she had disease relapse, so who knows how well that's managed. And then the last thing, yeah, again, tuberculosis, just come back to that, sorry to go back to infections, but like, she's had been indeterminate, as we've discussed. IGRA doesn't rule out active disease, especially in an immunocompromised patient. So that is certainly a consideration always.
And then I guess I mentioned imaging, but in terms of other lab testing, we love sputum. If she can cough something up, we'd love to collect it. And then there are lots of advanced tests that we can talk about in terms of like fungal testing, serologic fungal testing, viral testing, viral swabs, and then AFB cultures of the sputum, all that kind of stuff. And that can in part be guided by what her imaging may look like. And then you guys have already written echocardiogram up here, which I think is also totally reasonable. Chronic cough and sort of this kind of indolent picture in someone who has leukemia could potentially mean cardiac pathology. But again, what we talked about, infection is most likely.
Yeah, I love y'all's breakdown of types of infection based on the tempo, and it sounds like because of the tempo of 6 weeks and subacute, you're thinking more fungal atypical organisms. And interesting, you had a similar case like 2 weeks ago with an immunocompromised patient who had lung lesions and skin lesions, but the discussion was infectious disease, and it was like a very, very similar discussion as well. So I think you're on the right track. Back to you, Deborah.
I have a question. Alex said that the leukemia can spread to the lungs, and I want to know, like, what is more common to see in the lungs in patients who had leukemia?
So it can look like anything. And I'm thinking back to my residency days, because these days, to be honest, and fellowship days, I don't see that many patients with leukemia, but it can look like it can be it can be more infiltrative, looking almost like interstitial process. It can be more nodular. It just depends. And oftentimes it's very difficult. It's a diagnosis of exclusion, and often it's hard to diagnose and without a tissue biopsy. So and these patients can be really hard to biopsy if this person's blood counts are okay, but a person who's really has really low platelets, for example, can be hard to do a biopsy on. But yeah, it can kind of look like anything. So it's not that helpful.
Thank you. So going for the image, the CT test showed like a lobulated growing lobulated growing right lower lobe mass measuring 343 centimeters. That has been seen for the last 2 years, but it was now grow 1 centimeter more. The patient was unable to produce sputum, and some urine histoplasma antigen was negative. Some serum blastomycosis antigen was negative. Serum galactoman and serum 1.113 beta D glucan was negative. And I think someone asked for electrocardiogram and was normal. And I think I can stop here now.
And if you give me one moment, I'll share the image as well, and
Okay.
I'll put it in the chat. I'll put it, sorry, on the screen.
Yeah, so while we're pulling that up, I would just say that, when you said growing mass, immediately my thought went to, well, I guess I shouldn't speak before I look at it. We'll take a look at it together. So my first question was really, is it cavitary or not? Because like if it's a cavitary lesion, then we're thinking something in the spectrum of fungal or mycobacterial disease. That would be really, really top of my list, or some kind of cavitary pneumonia. Perhaps a cavitary cancer, secondary, other cancer unrelated. But here it looks like, from what I'm seeing, it does not cavitate. It looks like it's a totally soft tissue density. And from what I'm seeing on the left image, at least to my left, is that I don't know if it's abutting the rib, may even be invading into the rib. And if we had, perhaps if we had a few more cuts, that would be helpful, but that's okay if not. But that is obviously very concerning for possible malignancy, if indeed it is like invading into the rib there. And then it looks like we have a couple other lesions, and again, with only 2 cuts, it's hard to say. On the other image, and are those connected or are those separate lesions? It's hard to know. Any idea, Deborah or Yusuf?
I think these are the only images we have, but Deborah
Okay.
had like the official read, and the read was like single lesion.
Single lesion. Okay, so somehow those are connected. Okay.
Is the image on the right a prior image and the image on the left a now image? Is that what we're looking at?
That is right.
Okay,
That's correct.
that makes sense. Okay, that makes sense. Okay. And it was over what time period? Was it 2 years prior?
Yes, 2 years prior.
2 years prior. Okay. Well, I mean, that is helpful. It's certain, if indeed it is the same lesion, which it looks like it's in roughly the similar region of the lung, then, well, I won't speak. Maddie, what do you think?
So I think Alex brought up some really good points, which is that if you think about like a big cavitary lung lesion or a big spot in the lung that develops over time, you will often think about like cavitating infections, fungal infections. And then the malignancy piece of it, I think, is really better identified by the time course. So that's why old images are so important to us. So if you have a lung mass and someone tells you, hey, this patient has a big right lower lobe mass, the first question you're asking is, do we have old images? Because I want to know over what time period did this develop? And if it's a short time period and a big cavitary lesion, that really points you more toward infectious causes, fungal infections, cavitating pneumonias, multi-drug pneumonias, that kind of thing. I'm sorry, multi-organism pneumonias. But if the nodule exists many years ago and has progressed over time, and the patient demonstrates other risk factors like has been on immunosuppression, that raises the concern, and there's no cavitating component, or really regardless, it raises the concern of like a solid tumor growing in the lungs, like a malignancy.
Yeah, absolutely. And I mean, I would say based on these couple of images here, really not seeing any suggestion that this would be like a fungal pneumonia, fungal infection, which I think was sort of at the top of our differential. So we might have to shake that up. You know, and what I mean by that, there's no cavitation, there's no halo around the lesion, which often indicates that there's some inflammation going on, which again is characteristic for something like aspergillus. I mean, this just looks like a solid mass that's, for all intents and purposes, growing relatively slowly over a couple of years. And one would be, to be honest, I'm not convinced that this would be in any way related even to this patient's AML, and this could be just a separate lung cancer possibly. So I would be interested in, so you said this was a non-smoker, right? Okay, interesting. So, you know, if the patient were, say, as many of our veterans are, three pack a day smoker for 50 years, I would say this is definitely lung cancer until proven otherwise. And we have to think a little creatively here, though. I think keep some other things under consideration. Yeah, so I guess I'll stop there.
Yeah, thank you both. I like how the first aliquot was acute versus subacute, and now we're subacute versus chronic. We're going through the time zone. So back to you, Deborah.
So, the biopsy of the lung node show like no evidence of malignancy, and some necrotizing granulomas was noted. The PCR test for Mycobacterium tuberculosis was negative. And in the next aliquot, I will reveal the diagnosis.
This is fascinating.
Yeah, this is getting really interesting, guys.
Yeah, so thanks. And we should have said, of course, that like, you know, tissue is the issue. Like basically
Yes.
you would need a biopsy of this. And then this thing looks easy to biopsy in a way, probably percutaneously. You can pretty much imagine like you could stick a needle right through the skin in between those ribs to get at that biopsy. And that would probably be the right move, assuming that the patient doesn't have other disease elsewhere or other enlarged lymph nodes, for example, in the mediastinum. You know, in which case we might take a different approach. But sounds like I'm assuming they probably did just a core needle biopsy of this lesion. Very, very interesting. You know, I think my pretest probability again for cancer was really quite high, given the slow growth of this really dense appearing lesion. I would want to be darn sure that the pathologist looked at it carefully, that we got a good biopsy, that really they didn't see any malignancy, and I take it for their word. And so the presence of necrotizing granulomas is really interesting, and I don't want to go on too long. I'll let Maddie talk, but basically necrotizing granulomas can arise from a variety of causes. Again, coming back to it, the most important causes of necrotizing granulomas are chronic infections. Those would be, again, mycobacterial infections, fungal infections. But there are some other non-infectious causes of necrotizing granulomas, like, for example, GPA, granulomatosis with polyangiitis, other vasculitides. You know, sarcoid again can present with granulomas. They're not typically necrotizing, but again, it depends how your pathologist interprets them. Rheumatoid arthritis can present with necrotizing granulomas, I believe. Don't quote me on that. I believe that's correct. And then in some section of patients, we never really determine what they're from. Although in this patient, I would be surprised if we don't find out what it is. Nocardia, thank you. That's a great one. Thanks for bringing that one up. Yes, that's a great thought.
What do you think, Maddie?
I think it's a wonderful differential. As you can tell, we're both kind of surprised at the pathology results, and that happens a lot. And I think if we were to discuss this case, before we send this patient for biopsy, the way that we would talk about their testing, we would certainly send infectious testing from the tissue sample itself. So we'd send grindable tissues, AFB cultures off the tissues. Some of these organisms are really difficult to grow. Nocardia in particular, TB is sometimes difficult. Like non-tuberculosis mycobacterium is difficult to grow. And so we would get really good samples and we would send grindable tissue cultures from those good samples. And we would plan to do that in advance of the procedure. And then we would also plan to get good samples just for pathology for exactly this reason. So I agree. I'm surprised by the pathology, but I think this is something we kind of routinely do when we are suspicious for some sort of fungal infection or malignancy. We would send the tissue cultures as well, or plan to. In terms of a lot of the kind of diagnoses that I think about associated with necrotizing or even non-necrotizing granulomas, not many of them would I anticipate happening in a patient with AML and who is on immunosuppression. So things like sarcoidosis or EGPA, rheumatoid arthritis, those are not typical, I don't think, for this particular patient. So infection is still, I think, high on the differential at this point. Yeah, tough case, good case.
Yeah. Similarly, when I saw this case, it was also interesting to me that it was only one lesion with a normal kidney function and no other fingerprint otherwhere to help us discern a systemic etiology. So similarly, I was thinking of could this be an infection or a slow grower or something very, very, very slow on the scale of years? But can't wait to hear more, Deborah.
Amazing discussion. So the cultures from the lung nodal biopsy grow Mycobacterium avium complex, and the patient was diagnosed with Mycobacterium avium complex infection. It was really amazing, the discussion.
I think that's really interesting. I don't know, Alex, if you've seen Mycobacterium avium complex present as an isolated lower lobe mass like this. I've never seen that. Typically, what we see from Mycobacterium avium complex is disseminated disease, tree and bud opacities diffusely, sometimes little kind of cavitations and nodular disease. But this is an interesting presentation of that. Alex, could you speak to that? You have more experience, I think, than I do.
No, this is highly unusual. At least in again, I'm not an infectious disease expert, but this is really, really unusual. Usually, well, for a variety of reasons. One is usually when we think about MAC, we think about multiple lesions scattered throughout the lung. Often it causes these sort of tree and bud opacities that are widely disseminated. Yes, they can certainly produce these fibrocavitary lesions, which again, this is really weird because there's not really cavitation here. Yeah, I'm just I'm really surprised. I mean, but I guess anything along the mycobacterial in the mycobacterial family can present in any way it wants, and I guess this could be one of these strange cases. But I think this is almost case reportable. It's that I think it's really quite unusual and interesting. I don't want to be belabor it, but I really think it is essential in this case to be absolutely certain that you didn't just isolate Mycobacterium avium as a passenger, as opposed to the actual true cause of this disease. And I'm not questioning the diagnosis. It sounds like that was solid, but in real clinical practice, one wants to be really, really careful that we just didn't find this bug, which MAC is really common, and it wasn't just somehow living in this tissue or whatever, whereas there's an underlying malignancy. So the type of biopsy really, really matters, and that we got really good samples. So
Yeah, I think that's a wonderful point. And if you don't get the answer you're expecting, you kind of have to be a little suspicious about the results and the quality of the test that you performed. So if your pretest probability for malignancy was so high and you get an answer that you weren't expecting, this might be a person that would not unreasonably undergo another biopsy just to be sure that we're not missing anything. Because if you think about areas of the lung that you're biopsying, you're sticking a 19 gauge needle, that's probably the biggest you're going to get in there, into this big mass. And there's many different areas of this mass that, you know, maybe malignancy or maybe inflammation around malignancy. So you want to be sure that you're sampling, getting a quality sample, especially if if your sort of ultimate results don't fit with what you were really suspicious for.
Yeah, it sounds like an unusual presentation of a rare disease because it typically presents differently. Deborah, did you have any teaching points you had from the case or when you were like reading about it?
Yeah, like I always thought about Mycobacterium avium, especially on HIV patients, but seems like from what I read, it's kind of increasing in patients that have like they are immunosuppressed. So that was like something that I thought that was really interesting. But it was a really great discussion. Thank you so much.
Yeah, thank you. And Alex and Maddie, I wanted to ask you if you wanted like the student listening to take one or two teaching points from the case, what would you want them to like learn or think about?
A couple things from this case. So I think asking a really good question and thinking about what your answer may be beforehand is a really important tool in medicine. I think a lot of times we will send out a whole battery of tests and just say, oh, well, we'll catch something. But if you don't think critically about the test that you're requesting, you may end up with kind of confusing results. And so that's an important thing, although it didn't apply in this case necessarily. I think it's an important thing to consider ongoing. And then the other thing I would just say is when people have complex histories like this patient, who are immunocompromised, have many medications that make them immunocompromised, have malignancy history, those folks are at risk for basically anything. So make sure you keep your differential broad. I think we did a decent job of that, but it can be challenging sometimes when you see something on an image that looks like a certain thing and you're like, oh, I'm positive that's a lung cancer, and it ends up being something else. So try to keep your differential broad and make sure you're asking good questions and anticipating the results so you can think critically about the information that you're receiving.
Yeah, and I think I would come back to my earlier, that was great, Maddie. I would come back to my earlier point, which is that taking care of patients, consulting upon patients who have malignancy, and of course, there are now many patients living with cancer who are really doing quite well on immunotherapy or on other targeted therapies. I think one can be just overwhelmed. I know I was certainly when I was an intern rotating on like the bone marrow transplant service and seeing like the long list of medications and treatments that patients had, half of which I couldn't even pronounce. But I'm trying to keep things trying to keep things in a relatively simple framework again, which is that when patients come in sick and they have an underlying cancer, it's usually it's either related to the cancer directly or the treatment of the cancer, sorry, I should say effects of the cancer and its effect on the body, or there's some complication related to the treatment that's causing, again, either direct toxicity or in immunocompromised state. And in this patient, again, we considered some of the things like drug toxicity, which again didn't seem likely based on the imaging, didn't seem like the patient's AML was necessarily progressed. It sounded like they had control with this FLT inhibitor. So it didn't seem like that was going on. But what it was in fact, it sounds like this patient became more immunosuppressed with their cancer or their treatment. And as a result, they had underlying probably MAC, an underlying AFB infection, which then kind of took off and grew in the setting of treatment. So ultimately, that's what it came down to. And then, of course, as Maddie said, keeping especially your infectious differential really broad is very important. I think the last point I would just make is that, again, when we're dealing with infections in the lung in particular, it's usually like a two-step process. First, we will get we want to get direct samples from the lung, and usually that starts out with sputum. If the sputum isn't adequate and doesn't give us the answer, the next step is to do a washing or a BAL, where we put saline into the lungs and then wash it back. And that's usually our first step to look for infection, rule out infections. But ultimately, if we're confronted with this, so something like this, like a mass lesion or something else that's really hard to diagnose, otherwise we're usually left with doing a tissue biopsy. And again, really ensuring that the quality of your biopsy is good is vitally important to getting to the right answer and treating the patient appropriately.
Thank you both so much. I think we all learned a lot, including like how to think about syndromes, the acuity. I don't think I've ever seen anyone get so excited about a necrotizing granuloma. So we can tell about your passion for pulmonary critical care. We could hear it in your voices. So thank you both for joining. And thank you everyone for joining. Hope you have a wonderful Monday and have a great day.
Yeah, thanks guys for inviting us. It was really wonderful. It was fun.
Thanks. I had a great time. It's great to be here.